honor for me to be here. So we will start with the first presentation, which is about the strengths and the limitations of the different image modalities as we see here in diagnosing elbow dysplasia in dogs. So if we talk about elbow pathology in general, a lot of pathologies are listed here, and the major group is the group of the elbow dysplasia, which contains medial coronoid disease, OCD, the UAP, and the cases suffering of incongruity. We know that the majority of dogs is presented with MCD, medial coronoid disease. Besides the elbow dysplasia, now and then we see cases suffering from incomplete ossification of the humeral condyle. It's not so often that we see those dogs, but it's important, of course, that we can pick up these lesions as well. And I have an example about that pathology later. Then we have the cases of flexor tendon pathology. I will talk about that later more extensively. And then we have the cartilage disorders, which are questionable. As we know, the cartilage in dogs and certainly in the elbow is very thin. And with the imaging modalities that we have available, it's often difficult to visualize cartilage. So about the radiographic signs of fragmented coronoid process, on a radiograph, of course, we would like to visualize the fragment. And we can, in cases when the fragment is displaced, then it's obvious that we can pick up the coronoid pathology. But usually the fragments are very subtle and non-displaced, and then it's difficult to pick them up on a radiograph. So the directions or projections we take of an elbow radiograph, the mediolateral and also the craniocaudal one, and if fragments are non-displaced and localized in between the radial heads and the medial coronoid process, it's difficult to pick them up. Unless the fragments are, the fracture line is parallel with the primary beam, but it's rare, then we can pick up those lesions, but usually it's not the case that our primary beam is parallel with the fracture line. So if we take a radiograph, we have to base ourselves on subtle lesions, secondary findings that can diagnose or helps us to diagnose that there's something wrong with the coronoid process. So Professor Hazewinkel went in detail yesterday about the osteophytes formation within the elbow joints at the specific places in the elbow where osteophytes and arthrosis occur. Also, as secondary, we look to the abnormal or normal delineation of the coronoid silhouettes, and we look to the subtrochlear sclerosis of the proximal ulna. And this is a difficult one, as it's quite subjective, the interpretation of the incidence of sclerosis. So, in general, we take these radiographs to start with the flexed mediolateral one, and on the left we have a normal X-ray, where the bone is nicely delineated. All the three bones are very sharply presented on this image. Also, if we look to the delineation of the coronoid process, it's having a nice homogeneous density, nicely delineated, triangular shape, concave shape. And this area is the area where we can visualize sclerosis. However, this is the normal trabecular pattern that we pick up in a normal X-ray as we see here. In contrast to this X-ray, we have a lot of irregularities, certainly on the border of the ankylosing process, the cranial tip of the radial head, the medial humeral condyle, and also the delineation of the lateral one is very blurred. That are the specific areas, as seen in detail yesterday, where osteophytes arise. Then secondarily, we tried to visualize the delineation of the coronoid process, and here our line stops here and it's going straight up, so there's no triangular shape anymore. And also, if we look to the density, it's very irregular, inhomogeneous. And then the area of the sclerosis, if we compare this area to this one, is bright, white. So here we are dealing with subchondral, trochlear and subchondral sclerosis in this ulna. So here we can be sure that we are dealing with fragmented conoid process. Then a study we did a few years ago where we compared the radiographic findings of arthrosis in 150 elbows. And we compared these findings with arthroscopic findings. So all these elbows were scoped as well. So in total, 150 elbows. If we look to the ones that were scored positive for arthrosis, that were in total 122 elbows, and in 87 of them, the finding of a fragmented conoid process could be confirmed on arthroscopy. In 35 cases, however, there was arthrosis. There were no findings at the level of the conoid on arthroscopy. So it means that we were dealing with false positive cases, 35 of them. Cases that were scored negative on the radiograph were in total 28. 19 of them, however, negative of arthrosis, were having conoid pathology. These were in general young animals, and 9 of them, the fragment was not present, so a normal conoid process. So what does it mean in general? That osteophyte formation is a bad predictor for medial conoid disease. So the incidence of arthrosis is, in general, meaning that there's something wrong of the joint, but it's a bad predictor for predicting medial conoid process. And also Fitzpatrick did almost similar research, and he came up with the same findings. So the radiographic findings supporting medial conoid disease, the lack of visualization of the medial conoid process, and again on this extended view, we try to follow the conoid process, but there is no conoid process. The line is immediately going up, upwards. If we compare it to the normal one, how it should be, we can be sure that there is medial conoid disease and probably a conoid process fragmentation in this case. Then the next one where we see, and here we are lucky, we see the fracture line, and this is the fragment a little bit displaced, not very much, but we are lucky that we can pick it up here. So if we try to follow the delineation, it stops here, it's blurred and homogeneous density. Then the subtrochlear sclerosis, if we look to this area, in this radiograph, it's much brighter, more pronounced in comparison how it should be. So these are cases with sclerosis and both suffering from elbow or medial conoid process disease. This one, it's a tricky one. We can try to follow the delineation of the conoid process. However, it's not triangular anymore. It's not concave. There's a bump, a bulge, meaning that also this conoid process is abnormal. So it are really subtle findings that we are dealing with to help us to make up our diagnosis. Regarding the radiographic findings, usually are the blurring of the cranial edge and or the abnormal shape of the medial conoid process and the incidence of sclerosis at the base of the conoid. Quite some publications have been written about these findings, but none of them compared the 3 findings together. So the accuracy of the 3 findings together, we tried to do, and I will explain it later. But important as well, if you look to a radiograph, and it's not only radiographs, but in any imaging modality and also in any surgical procedure, you have to be skilled, you have to be trained, you have to be experienced, that you know what you are doing and know where you are looking at. And that's a nice study they did in Germany, where they compared the radiographic findings with CT findings, and it's obvious that radiography is inferior to CT. But also what is important is that they came up with the conclusion that imaging and the diagnosis of medial coronoid disease. And this is a group of dogs suffering from elbow lameness. So they were presented in the clinic. What we did was take the three standard views we are usually doing in Belgium. It's the lateral extended, lateral flexed, and the craniocaudal view. And then we tried to find out if CT could be the gold standard in relationship to arthroscopy. So we worked on 180 elbows, dogs of different ages and different breeds. A lot of them were Labradors and Golden and Bernese Mountain Dog. However, also unusual dogs unusual breeds were included. So all dogs were suffering from elbow lameness. The three standard views were taken. The CT images were taken of all elbows, and arthroscopic procedure was performed in the affected elbows in 141 of them. So we came up with a set like this, and they were scored by two people who scored them in a consensus, and in cases where there was doubt or discussion, a consensus was reached to score these sets of images separately. So what about the results? So 141 were scoped, and this is a study comparing the arthroscopic findings with the CT findings. If we look here, the cases that were negative on CT, meaning that there was no affection of the medial coronoid process, no sclerosis, these all could be confirmed on arthroscopy. So all of them were normally scored on arthroscopy. The ones that were scored as having pathology got a 1 of scoring, were also checked arthroscopically. That were 128 cases on CT, and almost all could be confirmed on arthroscopy as having coronoid pathology. One was having a negative arthroscopic finding, meaning this was a false positive result. The correlation between the CT findings and arthroscopic findings were very, very good, as we see here. Also high sensitivity and a very high specificity. So the conclusion of this study is that CT could be used as a gold standard in relationship to arthroscopy. So the one that was scored positive on CT is this one, and this is a very atypical pug. However, he was lame on his front leg and suspicious of having elbow pathology. These are the sets of x-rays, the right one and the left elbow. And if we look to the coronoid process and try to follow it, if we look to this area for sclerosis, also on this radiograph, and on the left the same, it's an irregular delineation, inhomogeneous density, and here for sure it's very unwell delineated, the coronoid process, and brightness here, sclerosis. So this dog was positively scored on the radiograph as having coronoid pathology. These are the CT images, transverse images at the level of the head of the radius and the surface of the medial coronoid process, the right one and the left one. The left one was scored on CT as being normal delineation of the tip of the coronoid process, and on the right we were actually sure that we were dealing with this hypodense lesion, meaning medial coronoid disease. Then the arthroscopic findings, or arthroscopist was able to insert the scope in such a small joint. The finding was that in the right elbow there was a normal coronoid process. So the conclusion, of course, is this is a very atypical breed that we missed on CT. Then the second part of the study was checking the reliability of the radiographic findings with CT. And this was done in all 180 elbows. And if we look to the ones that were scored negative on the CT, that were 39 of them, in 14 they were scored for having X-ray findings for coronoid pathology, 14 out of them. Then the ones that were scored negatively on the radiographs could be confirmed, 25 of them. In 3 of them, they were having lesions on CT. So there were false positive ones, 14 in this examination, and false negative ones, 3. So the sensitivity is still very high, the specificity is lower, meaning that radiographic evaluation is not too bad or not doing bad. So in patients, it's possible, of course, that you overdiagnose a bit on the radiographs, however, that the medial coronoid process might be normal on CT. So this is a case that we scored in this study. It was a Labrador of 20 months old, and if we look to the 3 different radiographs, we see some bulge here, a small bulge of new bone formation. The area of the trochlear notch looks a bit sclerotic. The delineation, we are missing a little bit the sharp delineation of the medial coronoid process, and also it's a little bit inhomogeneous. And these are the corresponding CT images, the medial coronoid process, the head of the radius, and this is the non-displaced, very subtle lesion that we could pick up on this CT image that could be confirmed on arthroscopy. So the arthroscopic view is the medial one. We enter the joint by the medial side. So the first we see is the medial coronoid process in the depth of the radial head, and this is the medial humeral condyle, and this is the fission line, the fracture line in the cartilage and in the subchondral bone underneath the cartilage as well. So the same fragment as we saw here. Then the second aim of the study was that we did almost the same. Material and methods are almost the same. However, this was done in dogs presented for screening. So majority of assistant dogs, helping dogs, police dogs. So we did the same procedure, compared the radiographic findings with the CT findings, and these are the results. So 424. The ones that were scored positive on the radiograph were in total 46 of them. They were scored positively on CT as well in 17, and however scored positive on the radiograph, negative on CT. Then the ones scored negative on the radiograph as being healthy, 9 out of them were having coronoid pathology. So false negative, 9. False positive, 29. And then if we compare both results, the lame dogs, the screened dogs, of course the prevalence in the healthy dogs, the screened dogs, is much lower as in the lame dogs, so only 6% really suffered from elbow pathology. But the group of the false positive is much higher in the screen group, and also the ones of the false negative ones is higher in the screen group. What does it mean? It means that we are actually a little bit over-interpreting on a radiograph. We are quite sure on a radiograph, however, in doubtful cases, it's important to check on CT whether we are right or wrong on a radiograph. As we see these results, in these cases, it is important. So what we can result is that radiography is better in discrimination of healthy joints from MCD joints. If we look to this number of cases or number of elbows at least, they are negative on the radiograph, negative on MCD. So it's quite good in distinguishing healthy from diseased elbows. So another example of a CV of 22 months old, again the 3 views. If we look to the delineation of the bone, there's no arthrosis present in this case. Interesting here is a little bit sclerosis, but what's even more interesting is if we look to the delineation of the medial coronoid process, that will actually look normal on the flex joint. It's nicely delineated, quite homogeneous density. And if we look on the flex joint, we miss the delineation, on the extended at least, sorry. we miss the delineation of the medial coronoid process, and it's quite inhomogeneous in this area. However, if we would only score the flex one, we would conclude this one is normal. And these are the corresponding CT images. Sorry, I went too fast. At the level of the surface of the medial coronoid process, we see the dark line here, the fracture line, the fissure line, meaning this is a non-displaced fragment in this elbow. So it's interesting, I think, if you look between the two views, the findings of the coronoid process itself. Something about OCD. It's not so difficult, or at least it might be difficult on the radiograph to pick up OCD. We need craniocaudal view, which is necessary to pick up those lesions. And also it's important that we rotate a little bit obliquity of 15 degrees, that we really see the medial compartment of the elbow in order to visualize and see the delineation of the medial humeral condyle itself. If we look to CT, it's really easy to pick up OCD. This is the level of the distal part of the medial humeral condyle, the lateral humeral condyle, and in this area we see the lip of the cranial part of the radial head. So we see all three bones on this image: ulna, lateral condyle, medial, and a part of the radius. This is an example of an OCD lesion where we have the circular hypodensity surrounded by an area of sclerosis. This is a typical finding on CT, and it's the same this finding in a shoulder joint, in a dorsal joint, and in a stifle joint of an OCD lesion. In contrast to this, if we look to an image like this, is the same level as that one, where we have huge new bone formation in all three bones, and if we look to the medial coronoid process, here how it should be, it's irregular with stripes, and this is a typical finding of kissing lesions, contact lesions. If a fragment at the medial coronoid process is displaced and it's moving, contacting the humeral condyle, the cartilage will eburnate and will be away, like we have in this image. It's pink subchondral bone we see on the humeral condyle, also on the medial coronoid process. This is a fragment, so the fragment is actually eburnating all the cartilage. This is a typical example of medial compartment syndrome. Then something about the OCD findings, the radiographic findings in relationship to CT, and I think it's obvious that the ones we diagnosed on CT, the number is much higher than on a radiograph. On a radiograph, we base ourselves on the flattening of the medial humeral condyle. If we are lucky, we see the radiolucent area as well, but it's obvious that the cases that we could diagnose on CT are much higher, of being sure that we were dealing with OCD. As you see, the specificity is high, the sensitivity is quite low in this study. This is a very young animal, a Rottweiler of 6 months old, suffering from left elbow lameness, and the problem in these animals is that the growth plates are still open. You see here. So, and that's actually hindering certainly the proximal one of the radius. It's covering the medial coronoid process on the lateral radiograph. So if we try to follow the medial coronoid process here, it's quite difficult to follow. This is too bright, subsclerosis is present. And if we look to the medial coronoid process here on this craniocaudal, and it's a little bit too straight, it's normal on this view. And these are the corresponding CT images, where we have already at the level of the humeral condyles, this is the ulna, a bright spot here on different levels, and a little bit lower, more distally, we see the hypodense, rounded lesions surrounded by sclerosis. And not only that, there is a small displaced fragment in this area at the level of the medial coronoid process. And this is the corresponding arthroscopic view, where the cartilage actually looks quite intact, also at the level where the OCD should be. So probably this is still an OC lesion. We can pick it up on a CT. However, in the cartilage, it was not visible. If we tried to palpate that area, immediately the cartilage came off and we could see the lesion. And this is the small fragment, non-displaced fragment at the level of the medial coronoid process and the radial head in the depth. Then something about scintigraphy. It's not routinely used. It's a technique you use if dogs are presented with lameness, and that with our clinical examination we cannot point out where the lameness is coming from. And also if the radiographs are doubtful, when we are not sure, then we use scintigraphy. It's having advantages as it's very, very sensitive. However, the difficulty is that the images are rough. They are quite blurred. No detail is visible, so the resolution is very low and the specificity as well. So besides that, we know in this case here we are having a hot spot, so from this examination we can be sure it's an elbow patient, and then secondary other techniques can be performed like CT or arthroscopy. So in order to increase the resolution, high-spec scintigraphy can be done, and this is a special camera with 3 heads. And specific collimators and filters are used to increase the resolution, and this is the image we gain. And if you compare with the radiograph, we can recognize quite well the different areas or anatomical areas. And this is a case, a high-spec image of an elbow patient suffering from coronoid pathology, so the hot spot in this image is quite well visible. And the corresponding displaced image of the same patient. Regarding ultrasound, the nice studies are described about ultrasound examination, and quite some or all soft tissues can be visualized, but the articular space is not reachable with a probe. So really evaluating the coronoid process is very difficult. Here we have an example where different flexor tendons are attached at the medial humeral condyle, and they are well visible, and also they are helpful for diagnosing those lesions. Here we have a longitudinal ultrasound image of the fragmented coronoid process, which is visible here as being displaced, and then we can be sure on ultrasound, okay, this is a coronoid process fracture or fragment, but we have a lot of false negative results in the study, as you can imagine, that we are not able to reach the articular space. Then MR, it's not routinely used in coronoid process disease or in elbow dysplasia. We did an anatomical study a few years ago where we tried to compare all the soft tissues with the anatomic specimens, and they are very nicely visible on these 2 sagittal images. As we see the superficial, the flexocarpi ulnaris with the 2 heads, the one at the humeral head and the one at the ulna, the ulnar head, and this is the extensor carpi radialis. So colleagues performed studies where they compared histopathology with arthroscopy and with the MR findings in elbow pathology, and the clinical relevance or the conclusion was that there was no correlation between histo changes and either MR or arthroscopic findings. So it's still disappointing MR in diagnosing elbow dysplasia. The cartilage is very thin in an elbow joint. If I may say, the cartilage in a shoulder joint at the level of the humeral head is only 0.6 millimeters thickness. In the tarsal joint, 0.2, 0.3. So you can imagine in the elbow it's very thin. And that's the problem if you compare to horses or human cartilage. It's quite well visible in MR. But you need a very, very high resolution in MR to visualize cartilage. So this is a case where we were looking on MR. This is a transverse T1 image, transverse T1 where we administer IV gadolinium, and the sagittal T2 image. And we are able to pick up very discrete change in signal in this area where the medial coronoid process is. How here you see it as well, quite subtle lesion. And the corresponding CT image here, even on CT as well, is subtle, a very subtle radiolucent line in the area of the coronoid process. Here it's more clear, a sagittal stir view, where we see the joint fluid going in between the fragment and the rest of the ulna. So it's of limited use, at least in our experience. Then, but I'm not hoping the images I show are low field images, low field MR. So these days clinics have high field MR devices which have a very large resolution and probably will visualize all structures more in detail. This is an OCD case. This is quite well visible on MR. The sagittal image, sagittal and a transfer. First, where we see a hypo-intense signal at the level of the distal part of the medial humeral condyle, here as well, and here as well. And a corresponding OCD on CT, it's obvious. And here again, a discrete lesion on arthroscopy. Certain, almost a small crack is visible in the cartilage, but after palpating, the defect came visible. So, that about the different techniques, something more about CT, and I'm in the procedure as well where we are standardizing the technique and positioning of how CT should be done for examination of an elbow joint, at least for official scoring, for official breathing scoring. And we perform our studies in lateral recumbency. So the dog is very nice, but this is administered just that we could pull the head back outside of the gantry here. We only have both elbows inside the gantry. It provides much better quality images, and you see the feet are extended in order to perform the examination. So